very good evening to all of you. I am Darshika Shah from the Clinical Engagement Team at DocPlexus, your host for today. India between 2010 to 2019 saw an increase in the rate of cancer cases from 1.1% to 2%. While the pandemic led to a massive decline in screening, a study reported over 1.4 million cancer cases in India in 2020. So this year, to commemorate the World Cancer Day, DocPlexus will be hosting a three-day event, the Global Onco Conversations 2022, to address several pressing issues around the cancer care gap, where experts from across the country will participate in various clinical sessions and updates in cancer care to help the community of healthcare practitioners. So stay tuned.
Good evening and welcome to all of you. Today I'm Dr. Jayalakshmi and I'm a senior consultant in radiation oncology from Artemis Hospital, Gurgaon, Haryana. And starting this session, which themed at closing the care gap in cancer care. And we are going to discuss about national and international perspectives in the care gap in cancer. And here I've got three eminent speakers. I'm first introducing Dr. Maman Chandi. I would consider him a mentor, sir. I worked with you in my earliest part of my life. When you started your first bone marrow transplant, I was there in Christian Medical College with you, and it's been an honor to work under you, which actually inspired me to go into radiation oncology. Dr. Maman Chandi is the Director, Clinical Hematology, Tata Medical Center, Kolkata. He's a pioneer in bone marrow transplantation in India, and he was involved in setting up the first sustained bone marrow transplantation program in the country in Christian Medical College, Vellore in 1986. He was conferred with the National Civilian Award, Padma Shri, and B.C. Roy Award by the Medical Council of India, and he has special interest in aplastic anemia, thalassemia, acute leukemia, stem cell transplantation. He has over 170 papers published to his credit. Eminent person in his own right who has set up a bone marrow transplant unit in Calcutta. Welcome to this session, sir. We are really looking forward to your inputs in particularly hemato-oncology.
Thank you.
Our next eminent speaker is Dr. Jagdish Kulkarni. He's the Director, Minimal Invasive Robotic Surgery in Asian Cancer Institute, Kambala Hill Hospital, Mumbai. He has over 30 years of experience in performing radical prostatectomies and cystectomies, and he has been awarded several prizes and scholarships during MCH in urology training. He is proficient in laser surgery and laparoscopic oncology surgeries, and he is also editor-in-chief of the Indian Journal of Cancer with interest in genitourinary and gynecological malignancies. We welcome you to this session, sir, and I am looking forward to your inputs too.
Thank you. Thank you.
Our third speaker, a person from my own field, Dr. Nagaraj Huilgol, is the Chief of Radiation Oncology, Nanavati Max Super Speciality Hospital, Mumbai. He's a radiation oncologist with almost 43 years of experience. He's a top player in the category of oncologists in Mumbai, having expertise in most complex procedures like cone biopsies, the IMRTs, IGRT, intraoperative radiotherapy, adaptive radiotherapies, radiosurgeries in all forms, which is gamma knife, SRS, SBRT, and with a special interest in hyperthermia. I welcome you to this session, sir, and I'm looking forward to your inputs too. When we look at the burden of cancer in India, we all know that the annual incidence is about 1.5 million cases per year. In a recent survey conducted by National Sample Survey Organization, this is from the Ministry of Statistics, GOI, they looked at what was the self-reported prevalence, and they found that it was around 83 per 100,000 population, and it increased in the urban scenario to about 100 to 110. When you go into the elderly, which is about 70 plus, it was 385. And particularly when it go into the elderly in the urban areas, the self-reported one, it was about 727. There is a varying scenario. And effective treatment, the reduction of cancer burden, and the early detection requires committed efforts and integration from the various sectors. This all of us know in our practice, and we are seeing also from the public and private sectors. It also requires looking at the gaps in the cancer treatment, approaches, and delivery. Now, every oncologist and every healthcare worker in cancer at some point gets associated with the following adjectives, which is affordable, equitable, comprehensive. So all this becomes a goal as well as a challenge at some time. So where are the gaps? One obvious and understandable gap is public health expenditure. In public health expenditure on cancer in India is below 10 US dollars per population. When you compare it to USA, it's somewhere around 100 US dollars. Of course, there are gaps even in the advanced countries. So that's an obvious and known one. But there are others too, and that is what we are going to have as a dialogue here. It would also help to highlight the gaps as well as the areas we have even tried to bridge it, the positives and the negatives. So going into this, I first would like to go on to what is the gap in terms of infrastructure. So I'm addressing this to you, Dr. Nagraj, who will go. What is this distribution of radiation machines in India, the external and internal, and in the government and private sector? Does it compare well with what we call as developed countries? Does it actually bridge the gap? And with fast advancing technology in radiotherapy, do you feel that all these advancing technologies are available to all sections of the population, or do we have to have somewhere around a common minimum area where each a person who requires radiation should be having at least an access to somewhere like a 3D CRT or something? So where do you think is the care gap? I start with you, sir.
Yeah, thank you so much for calling me here. And radiation oncology is a very capital intensive branch of oncology, wherein in fact the technology keeps getting more and more fancier and more expensive, and sometimes some of the technologies don't really have level 1 evidence, like say for instance photons. But then that becomes a coveted kind of technology. And like in wealth distribution, there is an incredible disparity. However, if you compare this over between the last 10 to 20 years, things have changed. Things are getting better in a private sector, but not so much in the public sector. The technology is sadly getting concentrated in the metropolitan cities and maybe level 1 cities or A cities, like say for instance Pune, and the metropolitan cities like Mumbai and Delhi and so on and so forth. They have a problem of plenty. So one of the things that we should do at this point of time is an oncology consortium say which is the optimal technology. What happens is everybody wants the latest technology, which is not necessary. And there's no point in buying an SRS enable linear accelerator in a small township wherein perhaps you don't really need it. So with some of these and maybe I mean it's not may not be really correct. Maybe there can be some kind of a rule by which you can say that distance between two radiation oncology centers need to be this much, because we have sometimes there are cities where in every 10 kilometers there's a radiotherapy center.
Yeah.
But if you compare compare Mumbai or Delhi with UP, the number of centers in UP are not even as many as centers in either Mumbai or Delhi. So that kind of a distribution problem is always there. Things are much better over a period of time. Maybe we should start talking optimal technology than the latest technology. And maybe we need to be, I don't say we should gag the manufacturers trying to induce or seduce the bias. But then I think we, or some of you as an academician, should say, look, this is what you need. And maybe we can also look at something like a pyramidal structure for making technologies, wherein, we have a pyramidal structure in the healthcare, So smaller villages can have maybe, simple machine with IMRT, to then you come up with more and more complex technology. I mean, that could be one approach.
That's very well said, sir. So, like out of, when you look at the district-wise distribution, there's only 40 out of 640 districts in India which have a radiation machine. So, to the bodies like our AROs and all, to influence policies to say at least have one district center, could that be, and they are also involved in the decision making, in the policy making before the budget session. Some, if we can have a common oncology group which is formed by hemato-oncologists, a representative from all the oncology groups, who say that we should have somewhere around this alone, at least this level at the district level. Maybe that is one of the things that we can think of.
Yeah, and maybe if we can also get the legislation. And not, it's very difficult to do that in a private sector. I understand that. Instead of having one at every next corner in a metropolitan city, or there can be fair incentives for the private sectors to set them up in a smaller cities. I'm glad some people have started, like Kolhapur has 2 or 3 of them, just as an example. And unfortunately, there's also, most of the southern states are doing fairly well vis-a-vis the northern states. And well, health is a state subject, so maybe the central government cannot do much, but then, the subsidies or incentives for smaller towns can be looked at or considered.
Wonderful, sir. Thank you. And my next question is to Dr. Maman Chandy. So you had set up a transplant unit in Kolkata. What were the major challenges? What was the gap that you found there, and the major challenges? And importantly, where do you feel that as healthcare workers and the GPs, where can they step in? Is it in counseling the patients, or their relatives? Where is it that they could come into this? Dr. Chandy.
Dr. Jayalakshmi, with your permission, can I sort of answer a little bit about your first question?
Sure, sir.
Because Taras are involved in setting up cancer care in the state of Assam in association with the government.
Yeah.
And they are planning on 16 linear accelerators in different peripheral centers.
Yeah.
Now, I can understand setting up a linear accelerator in a place like Kachar, where Ravi has already got a very good setup, and you have. But you stick one out in a place where the technician won't stay because his child cannot go to school. To get an engineer to come in when there's a repair needed, power is not reliable. So I've been thinking about this problem and thinking, maybe isn't it better to concentrate it in different areas, because commuting, travel and stay is a fraction of having the center close to your house. So should we think of the model that in each area, capacity will be built in tertiary care centers, and we'll provide enough infrastructure for patients and their families to stay, to have the treatment. This is an alternative model. After looking at what's happening in Assam, I'm beginning to think that this might be a different solution. Now, coming back to your question addressed to me. Starting bone marrow transplant is really dependent upon a tertiary level hospital where you have all of the infrastructure necessary. Because unlike plastic surgery or even robotic surgery, it is not a one-person dependent skill. It is a team which has to be built together. So if your laboratories are not the best, your transplant program will certainly flounder. So if I'm planning to use TBI, I need to have the best radiation oncologist to give TBI for my patient. So therefore, I believe expertise in BMT should be concentrated. But I agree with your point that the knowledge of availability and referral is poor. Right now, we are getting 10 lakhs per patient for thalassemia transplantation, and digressing a bit, from Coal India. But I don't have takers. So obviously, there's a gap between the referral pattern of practitioners, of doctors, of facilities, knowing that something's available and it's available at a cost which is unbelievably low. So that gap needs to be corrected.
That's something which is really interesting that you said. And in that aspect of when you said about TBI, sir, even when a facility, like let me talk about our facility, we are ready, we want to start. The only thing that we realized is that, you know, the dimensions of the room could never be altered because it was taken much earlier, and there is no way we could alter the dimension. We have been going back and forth with it for the past nearly 4 years. Only now, with, you know, probably thinking of putting in a machine like tomotherapy, then we are probably looking at, you know, an IMRT or an IGRT based. Whereas we don't even need that. When you start a program, you can very easily start with the simplest of the technologies also. But a simplest thing like taking a dimension of putting a machine in a linear accelerator, that can have a bearing on our TBI. This is something only now I understand. So there is a planning required at every stage. That's what we realize that.
I'd also like to add, since you're talking about gap, that when I started the transplant program, the cost of an allogeneic transplant in a European country was nothing less than $250,000.
Absolutely.
We can do it at 1/10 of the cost, with results are comparable. And that is what we have to make our people understand, that doing the state-of-the-art technology at 1/10 the cost in our country is possible, because our salary structures are different, and we do have a big space where NGOs and charities are operating.
That's fine. That is one thing which I thought I will allude to a little later. So I wanted to go into crowdfunding, how the things have changed, and I wanted to go into that a little later. Coming to then my next question is to Director Dr. Kulkarni, sir. The availability of manpower, in particular relation to, you know, super specialization, like what you said, surgical oncology, robotic surgeries, they have changed the outcomes, but where are we with the learning curve? What is the availability and the concentration more only towards the private sector? These are things I wanted from your side. Where is it that we can close the gap? Can we bring that on even to, you know, a person who is walking into a district hospital? At what point do you think that these sort of things will be available to them?
Good evening, and thank you for, you know, inviting me for this, and a very good question. In fact, that has been in my mind. Now, while talking about surgery, see, open surgery is the cheapest one. And around 1980s, we started with the minimal invasive, which really culminated into robotic surgery around 2000. Now, robotic technology, which has got several advantages in terms of, you know, less blood loss, and most important advantage. Am I audible?
Yeah, no.
Yeah. Now, the robotic surgery has advantages, which is, you know, less operating, less manpower loss, number one. Number two, painkillers are less used, blood loss is less, and patient can be back home within no time, or maybe very limited time. Having said that, it has also an added advantage of the surgeon comfort as well. But as Nagaraj said, these are capital intensive, very high amount of money required, one, and then recurring costs, which is also an important issue, which cannot, suppose if a machine costs about 12 crores, that's not the end of it. Because to remain the viable for that 12 crores, you have to have 18 cases to be done. And each case requires at least 1.5 lakh rupees instrument. Now in US, for that matter, where you have got about 3,700 robots today, whereas in India, as they say, robots are only 150 or so maybe 200. Having said that, their cost difference between open surgery and robotic is just $5,000, which is like 5,000 rupees. But here it is almost double to three times. So therefore, these are the issues which we have. But certainly there are the advantages. Now there is another thing which comes to my mind. And as you asked questions, these robots, out of these 250 robots, majority of robots are in metro cities and very limited in other cities. And in government sector, totally, barring all in institutes, wherever they have. They don't have this. So a student and the practitioners of the state of the art are deprived of this technology, which is 2 decades old. And how to circumvent this? How to circumvent this? And this is exactly what I suggest to my students. That suppose if you are practicing in Yavatmal, which is a small district in, say, Vidarbha, what you should do is 5 of the urologists take together, have only one machine rather than having each hospital. And here also I would suggest to the corporate hospitals, don't flood this in Mumbai. For that matter, there are 18 robots. We will be cutting into each other's fate. Instead, these robots could be transferred to smaller places and then make it open door policy. Those who are trained, they can use it, and then the benefit can be given to the patient. Of course, obviously, we are always talking about reduction in the cost of the instruments, but it will take time. We do not know these machines. Make companies are there, and then another thing which comes to our obstacle is insurance companies. Insurance, it took me about 10 years for them to understand that this is a new technology which should be adopted. And I said, you can start raising the premium if at all you want to do that, but don't deny this one, because you cannot ask the patient not to get the best, but go for a small because you are insured. That's one issue, which is absolutely a problematic, insurance company. Having said that, we are also working with, under the Prime Minister project with IIT Mumbai and Indian Robots. And I am happy to tell you that we have done some reverse engineering, and we should be having by 2026 or so. At this point, it's too early for me to say. We should have an Indian robot, which is, which will be more economical and, nice. Of course, available one. And that's what the message I would do. But the technology has come to stay. It should be made available, and it's our job to see that it goes down to the last digit. And I'm sure this is NGOs can come in. But again, here is, doctors have to have will together, work together. Absolutely. And I think here I would say cooperative group practice would be a good idea to circumvent these issues.
So you're talking more about cooperative groups. Yes. When we came in, you were talking about insurance. Yes. For a long time, I could not get the insurance to pay for CyberKnife because they said this surgery is not under our thing.
Exactly.
In spite of us giving them information about, CyberKnife being this, we took out even the printed information. So the understanding has to percolate at every level. Thank you for that. And Dr. Hulgal, would you want to talk about the, learning curve gap in radiation oncology, sir? Where do you find it, and how do you think that gap can be bridged?
So when it comes to radiation oncology, I think we are far more luckier than the surgeons were, at least surgeons in India were, for a simple reason. There are a lot of modules wherein you can simulate, say for instance, contouring. Now you are RTOG platform and many other platforms wherein you can share your information, knowledge, but you can also have contouring modules. So to me, I don't think it's such a big deal because many of those students can just go onto these sites, all these apps, and sit and contour and recontour and look at all other options. So learning digitally and interactively is possible in radiation oncology because you don't have to use a pair of hands like Jagdish and his colleagues would. Yeah. So I think that should not be much of a problem like it was before. I mean, it needs a little application, but it's not a formidable problem. I don't think so. Yeah.
How was it with you, sir, Dr. Chandi? When you look at people who are passing out and you're getting them, are we having enough hematologists? Where is the learning curve there? What is it from your side?
Actually, Dr. Jayalakshmi, this is something I am very passionate and upset about. Sure. The fact that our manpower is inadequate.
Yeah.
We can get enough linear accelerators if we want to.
Yes.
But we cannot get physicists. You give me some physicists if you have. What is the salary of physicist commands? Right? Because there just aren't enough physicists. You look at nuclear medicine. I want to start a national board training in nuclear medicine. I have a radiologist who's been reporting PET scans for 10 years. He cannot be considered. The educational bodies of our country cannot think out of the box. Absolutely. And say there is a severe manpower shortage. We have to think out of the box. We have to allow centers I'm not saying compromise on the examination or the candidate's knowledge and skill when he passes out, but at least allow more centers to come up when there's a massive manpower gap. How many PET scanners are coming into this country? And how many people do we have who can run these PET scans? How many physicists do we have?
So
We
in
are
this
in a crisis for that.
if I may pull in there, sir. You absolutely right when you pointed out the shortage of physicists. But the problem is also engaging at the government level. The reason being that I am sitting at a center like Delhi. Even the centers in Delhi, the government centers, are not able to stay with physicists for a long time. The major problem in one or two of the centers remained that their salary structure was stuck at some 1960s or something like that. So understanding that a physicist is an absolutely integral part of radiation oncology, and with the development of this particular field, we need to look at salary structures from that particular point of view also. So this exists even in the government sector. I think private sector to some extent has come up because it's a necessity from their point of view. But in the government sector, where mostly we are finding the Indian population which is coming at least at the first level before they move on to the private sector, the patients come on to the government sector. The retention of physicists, when it comes, there is a policy decision which needs to come in. And yes, so we come there again where we have to talk to the legislature somewhere.
If I can cross-question Dr. Kulkarni.
Yes.
I have 2 robotic surgeons for urology and 1 for gynecology. And both of them have left, getting twice the salary that I'm able to pay. And I'm paying a decent salary. Dr. Kulkarni.
Just to answer to that question, sir, in Metropolis, the transfer is very, very common. And this is exactly the, younger people fall prey to that. Because, for better pastures, all kinds of things. Having said that, there has to be some amount of dedication involved in that. And the way Tata, I've been part of Tata Memorial. So we were then committed for X number of years, or 25 years you spend, that's where it is. But these things will happen, sir. We'll have to accept this, because in America, today you are here, tomorrow you are there. And that's going to be, sort of exchange is going to be there. However, the best thing which can be done perhaps is, of course, is giving them the freedom of, which you would have given, I'm sure and these will come back. I'm sure the number of students we are producing, they will come. There is no question about that. And Tatas have a reputation, name, and there should be no problem. So this exchange will go on, sir. Now, as for the question, taking to madam's question about learning curve, and for that matter, what I have been suggesting to municipalities in Mumbai, municipal commissioner, that I can be a mentor for first 10 cases, and after I will not charge you, and these people can take over. And one thing which we have to look at the factor, especially in robot never tires. You can work round the clock. Now, who can work? People can be assigned timing 10 to 5, 5 to 10 p.m. Or you can do that because that's possible, because your hospital stay is very short. In that case, this can be circumvented. So learning curve is no problem, but there is a problem of shortage of manpower. And here I was leading to this, using the nursing specialties and nurses being trained for these kind of things.
My next question. That's coming to my next question.
Okay. There. Yeah, just coming about the
Dr. Phil.
Yeah, actually, but I understand that this, as I said, your problem should be slightly different because you would need a pair of hands on site. But when it comes to radiation oncology, I think it's about time we started integrating tele planning and image processing and all of that. So maybe if you, instead of 4 physicists, 1 or 2 of them can do it, we can put it on the cloud, we can centralize it. So I was listening to Professor Chandy about Assam. If you have the electricity on, net on, I think your peripheral centers can be run by some people sitting in Guwahati. That's absolutely not necessary. That you've got to have X number of physicists or technicians, of course, you need, but physicist problem can be, we need to innovate with the existing technology, and we need to dip in there. I mean, need to dip in there and see how we can, maximize the facility. And I think we're not using enough, except for HCG, which has a centralized planning system. I think many others don't really do that. I think we should, and that really reduces the number of people that you need.
Yeah, I think Dr. Hilgal's, what he was saying is true. So when they start out in HCG, most of the centers, they use the cloud system and then they go on. So this, if we can, partly at least, but still it doesn't sort of, circumvent the other problems, like what you said, machine downtimes and availability of engineers to such long distances. These things are a problem, but at least, from a physicist point of view, these things, to some extent, it can be.
Absolutely.
And the other thing also is
technology. Yeah. Therein comes appropriate technology.
Yeah. And the availability of a little newer technology, even on Cobalt. Halcyon has come up with IMRT machines, which has been in utilization in places like Rishikesh also. So the throughput could be a little better, and downtimes will be comparably less. So better utilization of such technology also probably is in the cards that we are looking for. Coming to my next question is, can increased utilization of nursing staff reduce the burden, particularly in the cancer care continuum, that is in the follow-up cares or in delivering ancillary cares? Sir, I'll start with you, Dr. Chandi, and I'll take all the inputs after this.
Dr. Jayalakshmi, I would love to give more and more to nurses. My bone marrow transplant unit is literally run by the nurses.
Sure.
They do everything for the patient, and they are very good. But there is a bigger crisis in nursing manpower than there is in medical manpower.
Absolutely.
My attrition rate of nurses is approximately 3% per month. That means 30% of my nursing workforce is turning over every year. So I have a budget for 500 nurses. I'm short of 100 nurses on my budget because I'm not able to recruit. I'm not able to retain. They will stay for 1 year, 2 years. They come out of nursing school knowing very little. Within a year, they become very good and they leave. So I feel that we have to now move from nurses to practitioners, nurse practitioners, who are just BScs in a science subject, and we train them to do a lot of things that the doctor would do and hand over.
That's a great idea.
We feel, and this is not unique to India. My son, who is a pediatric intensivist in Philadelphia, is crying every day saying, I don't have nurses. I'm closing beds because I don't have nurses. So
is it because COVID times, sir?
A worldwide shortage of nursing manpower. And though I would love to have a lot more nurses and hand over more things to them, there just aren't nurses available. And the quality of nurses.
That is, I mean, that's the same thing that we face in the,
Well, same thing. If I have to just take it to the surgical side, we are also having the similar problems because these nurses are changing every yearly or something. But I was just wondering whether we have one level down, which is called the auxiliary nurse midwives. They could be graduated, could be trained, and especially in the tier 2 cities or tier 3 cities where that can solve the problem. But again, this is a problem which is much across the world. I'm sure this is a problem. ANMs can be trained, and the role of telemedicine is going to be there. How practical, how easy, how cost effective it is, we do not know. But I think that is what we are looking forward to. And that's the only thing as far as therapy is concerned. But one more thing which I want to just come into, that is awareness programs. I think awareness programs are the more important also, And here the social media, as you know, like DocPlexus or something, can make a lot of impact. It's making already impact. And answering to the questions on a regular basis, I think this will be, as far as the diagnosis is concerned. The another question which is coming up these days is, what is the progeny chances? And here again, it opens up another new box of questions for the patient, especially in oncology. I think I would like to draw this attention to these kind of questions.
When you talked about awareness programs,
yeah.
Now we do have at every level, like you said, these sort of DocPlexes as well as our own conferences, and there are others where CME credits are being also, given to GPs unless they attend these sort of awareness programs. But still, to this day, you being a surgeon, I mean, don't you see once a month or so patients having an early CS cervix who has to be operated, just has a TAH with BSO without a lymphadenectomy, walks into your home. Similarly, a breast cancer, early breast cancer, where you have to get a true biopsy done. Here, there is a lumpectomy which is done, and then the patient comes in where it is a 2-stage surgery. Yeah, rather than putting it as a right or a wrong diagnosis, how is it that this is a major care gap? A patient who has to have probably a sentinel lymph node biopsy and then proceed, where there is not even a need for a axillary nodal dissection at that point. So we are unnecessarily, a 2-stage procedure, a heavier procedure. How are we going to, bridge these gaps?
I mean, I would do the one thing, of course, as you clearly said, you have to have a 3-level teaching. Say, for instance, general practitioners, medical students, specialists, and super specialists. They can be, various ways. They can be using social platforms or regular CMEs or something. But this is at fault for not teaching them that this is the right way. And again, there is also a small problem on our side. We are going on changing guidelines every 2 years, which becomes very difficult for anybody to continue. As you go on changing the auto care parts, it cannot happen that way in medicine. So we have to be also, guidelines which are, we duplicate from Western European guidelines, American guidelines, and our situations are fine. But that doesn't mean that we reinvent the wheels. But at the same time, we have not to go overboard and try to say, no, everybody has to follow this guideline. Again, these are the problems and local situations. But I think all medical fraternity at higher level needs to think about this, what you clearly said. And that's the question, which you've been answering for the last 25 years, I suppose.
Dr. Chandi, sir, the same question. How does awareness affect, like, for example, coming into, utility of BMT programs, particularly nowadays with multiple myelomas and lymphomas? Is there enough awareness among the practitioners? And do you see enough of them referring to you? How much is the utilization, sir?
To me, I think the availability of internet has provided 30% of India's population. They have already Googled you, they've already Googled the subject, and they come in pretty well prepared to ask you hundreds of questions, and I like that. And they are even there to question you, which I like that also. So for 30% of our population, I don't think there is an information gap. I think they have access to everything, and they know, they're well informed, sometimes misinformed, but at least they have access. But 70% of our population doesn't have that, and therefore the whole healthcare infrastructure has to be sort of educated so that right from the general practitioner, they are aware of what is available.
Absolutely.
And therefore, they don't say leukemia is untreatable, that this child with leukemia has to die, that there's a 90% chance this child can be cured if properly treated, but it may be expensive and may require a lot of effort, but they should know that. And that, as Dr. Kulkarni said, depends upon continuous education, CMEs, programs. And with COVID, I am happy to say that that is in fact on the rise.
Yes.
There is almost no day when there is
no
CME or a program to educate.
Dr. Hulgal, sir, would you want to come in here?
Yeah.
How do you feel that awareness is, changing your practice? Is there enough awareness? In my practice, I have people, patients and relatives sometimes walking in. It's the same thing, almost like what we see with Dr. Chandi.
Yeah.
Sometimes I have patients walking in when they say, we have to irradiate the pelvis, and they'll be talking about hair loss. So, what is it from your side?
Yeah, as Professor Chandy said, and Jagdish also said, see, there are a lot of people with an access to the net, and they do have a fair bit of awareness, understanding, knowledge, or misinformation or information, etc. That's a fact of life. And I think it's also linked with the socioeconomic status of the area. Now, if you go down south, I keep saying that, or even Maharashtra, which gets included there. So the socioeconomic status of most of the districts is pretty high, which means they have a fair bit of education, access to the technology, information base, so on and so forth. But when it comes to awareness, everybody's competing for their own branch. Okay, now somebody else will say, okay, I must talk about rheumatoid or something. Someone will say some of tuberculosis, so on and so forth. So you can't really be harvesting souls in that sense for only cancer. But I'm quite certain, much to say, look at the way reproduction has happened. It's just the education and the socioeconomic improvement in socioeconomic status and education makes all the difference. And that's a long process. It's not directly concerned with us, but it involves us. So once that happens, automatically the level of information goes up, and I'm sure we'll see more and more of early diagnosis as we go along, and that's happening. And secondly, again, I think when you're talking about awareness, COVID has taught you something. Almost every Indian in India has an opinion about COVID, right or wrong. Yeah. Or they will give an eloquent speech on the booster dose. So that is the power of media at large, be it social media or a regular media. So it has to be prudently and cost effectively utilized to inform people of certain diseases. I mean, if there's no point in talking of brain tumor every next day because that's so rare. I mean, if I can understand if you talk about breasts, prostate, and cervix, and focus on them and let people know, or even to an extent head and neck, more frequently. I mean, I see on NDTV almost every evening there's a program on diabetes, and also we have such planned, executed awareness utilizing all this cross media, and maybe that will be very useful.
Okay. My next question is utilization of general practitioners. Dr. Chandi sir, I'd start from you. Apart from a referral and, are we looking at them, or from palliative care? The palliative care is largely confined to GPs now. But do we look at a different role, more so from your particular point of view, in a hemato-oncologist and a medical oncologist point of view? Do we see a slightly different role also integrating them?
I certainly feel that having a good general practitioner who works with you is a plus for the patient. He's willing to call you. A post-bone marrow transplant patient gets an infection, and the doctor calls you and says, "Wonderful, what shall I do?" And that is really good, because then promptly what needs to be done can be done, and you can advise him. So I think it is a win-win situation where tertiary care centers have a whole group of general practitioners where the patient is coming from, who are willing to work with the tertiary level center to provide optimum care. Because patients are going back home. They need good local care, and an informed and caring general practitioner is his best insurance when he runs into trouble in his home area.
Dr. Kulkarni, would you like to come in? Particularly places like NHS and all. I mean, after surgery, the patient goes back. care. So
Yes.
something like that is going to help benefit you.
No, see, essentially, what happens is, especially when we started the robotic surgery, people didn't know, and we took a lot of time to, tell the general practitioner that this patient will go home on second day and third day, he might call you for some kind of thing. So if there were regular courses in Mumbai, we have got wards, IMA, we run their courses, but that's one point of the story. Having said that, we have to also look at the relatives. I think relatives also should be, especially young guy who is willing to learn, could be told that these problems can be solved at your property. And you can also, and of course, your availability should be there. As a physician who in charge, I should be also available. I mean, it's impossible for me to be available 24/7, but certainly as far as possible with the WhatsApp media or something, this could be definitely worked into. Now, general practitioners need is absolutely there. And we can also use some of the, paramedics, psychology students. These all can be trained to, get into these projects or something. I think ancillary disciplines could be invited to be participating, and that the medical treatment is not the domain of A, B, C, or D. It is practically effective. And of course, what you said was the palliative care, which is so important for us today. That death should be made painless as far as possible, and not a troublesome, because the relatives are also involved in this management. So one of the things which I normally do is, one of the relatives, I tell them, this you have to take care for next 2 to 3 months or something, and kindly report to me if you are nearby. And that's one area which we can look into. That would be my input.
Dr. Huilgal, sir, that's one. How do you look at the role of GPs?
Sure. I think when we're talking of the very traditional bag-carrying family physician, that's a dying breed, and especially in the bigger cities, you got to really look for them to find one. Okay. So having said that, what happens? Say, for instance, that somebody who has undergone prostate has come to me for radiation, etc., etc. Most of these people prefer to go back to their original surgeon. I'm sure I know that most of the people would like to go back to Jagdish when they come from him. So they trust their primary surgeons or physicians, whoever, or like ENT fellow has diagnosed something. So I also, when the people come from outside, if there's a gynecologist, even if they're not trained, I recommend that they go back to the gynecologist if there's a cervical tumor, or a general surgeon if there's a breast, or a neurologist if there's a brain tumor. So, I think that romantic idea of a general physician helping with the family in every moment of a health crisis is part of the novel. I don't think we'd get there anymore. So I think, but this is what I do. I mean, maybe others have a different experience, but this is what I do.
Dr. Lakshmi, if I can add, I find that the pediatricians are much more attuned than the adult physicians towards communicating with the tertiary level care. And they are very good. They will call you saying, can I immunize this child? Is it all right? So it's really very good to have that communication with the peripheral area.
Sir, even in the adult thing, I think Dr. Kulkarni would agree with me. We are definitely seeing a change now, because the physicians themselves, particularly when they're looking at it as their own practice, they find it good when they start communicating with the treating oncologist. Their practice also becomes better. So over the last, maybe, about 5-10 years, I'm seeing them responding better. When we, they tend to take back the patient. They tend to also check out with you when they have to come for follow-up. It's a slow trend, but, it has started. It's not that they're taking decisions.
If I can add a point, that sometimes physicians are scared to touch your patient.
Absolutely.
This guy is lymphoma. He can go back to Dr. Chandy. I'm not going to touch him, right? So in my discharge report, I often write, all intercurrent problems can be attended to by the patient's family doctor, stroke physician. So that sort of patient shows that to the physician, okay, you have been authorized to do this, so I'm comfortable with that.
Madam, if I have to add one more point, and it is, I was pleasantly surprised with, general practitioners asking me regarding the girls being inoculated with the HPV vaccine between 9 and 13. I think for last 20 years, there's the program which has gone where it's showing the things. People are understanding that this is needed or something. He says, sir, can we do this? I said, certainly, of course, you can do it. Whichever vaccine, you can take that, whatever. But I think HPV vaccine has got into the, especially younger girls between 9 and 13. I think that's where, as you said, there is a change. When we were students in the 80s, it was not there. I mean, general practitioners would not touch, as Professor Chandy said, they won't touch, no touch technique. Now this is where. But again, palliative care remains a big dogma for even general practitioners.
Coming to another, sure, sir. Please come in.
Even in palliative care, there are a lot of paradigm shift, and at least in Mumbai, I cannot vouch for other cities. There are innumerable home care centers which look at not just all the illnesses, but specifically cancer-related problems, home care, palliation, and it has it appears suddenly to be a very, very profitable business. In Mumbai, I have a long list of 10 to 15 companies, and they do it for profit. So, which means, it's there. And of course, in my department, we have clinical psychologists, and there is a separate pain management clinic called Shalmala, pain management palliative. So we do have. Having said that, in Mumbai itself, I have a list of more than 15 companies who do a domiciliary visits, palliation, pain management, and so on and so forth. So it is catching up, and it seems to be profitable. It looks like
business, yes.
My next question is about screening. I would like Dr. Kulkarni to come in. How do you feel is the screening scenario in India, and how do you see more of screen-detected cancers? Does India see that more, at least a fractionally better part?
I am, as I said,
regarding gynecological cancers.
In fact, our tagline now would be from a clinical cancer to subclinical cancer. That's what ultimately you are aiming at. And screening is a massive effort. And at this point, I don't think we can, but it can be obligatory. Patients coming there on their own by awareness coming in is a fine, absolutely fine. But nationwide programs we are way beyond. I think it's not effective at all. It's not cost effective at all to me. I would say, well, let's not spend that money on that. Let's say it obligatory. In the sense, people come to ask you, you give the opinion rather than, make it. There's one separate group which can be familial cancer. So, for instance, prostate. Mother breast cancer, father prostate cancer. Well, this could be, again, here you have to make them aware that please go and check rather than, but I'm a little skeptical about the viability of the screening program in India at this point of time. I'm sure others will have the same. Or what is their opinion?
How is it in your practice, Dr. Chandy? I mean, what about screening, in particularity about hematological malignancies or thalassemias? How is it? Okay.
I think malignancy in hematology, I really can't see a place for a screening program. These things come on so quickly. Suddenly they're so specialized that I don't think so. Thalassemia, I certainly believe a national screening program, which is actually implemented, where the patient pays for it. Anything given free is of no value at all. So any testing which is done is paid for by the patient. Whatever, something, you do some testing free, they don't care. They don't implement it. So you need to pay for what you get, and then you'll value what's been done, and you may follow the information. And if we can reduce the birth of children with thalassemia, that will be a great thing. With regard to screening for different diseases, I think India has to develop practical programs for each of these. And for instance, in our hospital, we've been involved with the DBT on a major systems medicine cluster where we're looking at cervical cancer screening by HPV. So technologies where the woman can actually do it herself, send in a swab, which can check for HPV, would therefore then She's negative, leave her alone. She's positive, she comes in and gets a colposcopy done and is followed up. So we have to innovate self-examination for breast, that women realize that that's what they have to do. For for prostate, for people who are above a particular age, should there be an annual checkup? Now I know that most corporate business ventures incorporate an annual screening, which includes a PSA, right? So the other question that Dr. Kulkarni said was that we have now started a familial cancer screening program. So we are fortunate that India's capacity in the area of genomics has expanded tremendously, and the private sector is now offering screening for BRCA, screening for whatever you want at a reasonable cost. But the education and knowledge and the availability of people who can give appropriate genetic counseling, because you can scare the life out of a person saying, you have this particular mutation and you're going to end up with cancer.
Absolutely.
All that. So we need to have people who are educated in genomics, because I think the infrastructure is now available throughout this country. And the understanding that molecular genetics is going to alter outcomes and is absolutely necessary in today's cancer treatment.
Very well said, sir. That was one field I thought I could, if we had time, we would go into it, the molecular genetics. Yeah. But, anyway, this was more of a, general topic. And so I didn't venture into that particular part. The other thing I wanted to check out with all the three of you is about the funding in treatments. Sir, I would start with you. You said that, Coal India had, Dr. Chandi, are there any other, what is the governmental level, and is there anything, the Impact Guru and this sort of crowdfunding, what is the impact of insurance in your field?
Yeah. Actually, if you look at our hospital, it's a charity. 800 crores investment from the Tata Group, and we try to keep costs low. But as cancer treatments are evolving, the cost of treatment is becoming enormous, particularly if you're going towards immunotherapies, targeted therapies, all that, the cost is really becoming too much.
Yeah.
So how are we meeting the need?
Yeah.
Number one is the Prime Minister actually does support almost every patient whom we apply for, up to a maximum of 3 lakhs. Currently, the national schemes that each state is running in Bengal, there's a Swasthya Sati program where 5 lakhs, and we are empaneled with Swasthya Sati. We are also empaneled with the Orissa government. 7 lakhs for a woman will be paid for by the Orissa state for a patient referred to our Center for Cancer Treatment.
Wonderful.
So increasingly, money is becoming available. At our own center, the Dorabji Tata Trust gives us 45 lakhs a month for subsidizing treatment. Pharma is stepping. Reddy's runs a SPARSH program at our center where we are able to give approximately 3 crores worth of drugs free. So crowdfunding. I'm amazed at the amount of money patients are able to get through crowdfunding platforms.
Yeah. Yeah.
So it is only the patient who comes and says, if you want to do, you collect the money. If the patient has the will and the determination and a little bit of internet savviness, he can actually raise considerable funding for the treatment.
Wonderful. Dr. Kulkarni, sir, how is it in the private sector that you find it?
Yeah, to give an example of Asian Cancer Institute, we have what is called as the Asian Cancer Foundation, and we do help that. But I must appreciate what Dr. Chandi said. This social media is a great asset to us. Yeah. That if you can utilize that social media, but again, you have to, your TPA guy should be in a position to tell them, look at this possibly. And maybe that will be one area where you can, and there the TPA guy also should know that this is available. And of course, last but not the least is, insurance companies. We have to convince them that this treatment has to be till the end, not only once a year. That's we have to. And another thing which, of course, I've told one of those insurance guys there was something called top up. if you say you are put up for this 15 lakhs or something, additional top up you can give. So more people are going to come into this, and this is how we can help these kind of situations for the needy. That's what I can say.
Have you seen insurance penetration becoming better over the years?
Yes, yes.
In your practice?
I think I must compliment the younger generation, because they are all very keen on this, and especially people who are in India or abroad. They want their parents to be included in this kind of thing. Yeah. They said, no, be done with it, and we do, especially all those things. And I think their younger generation has taken it by in their heart that my parents must be insured if they were not insured in the beginning, in the past. So I think yes, of course, yes.
I think all our views are basically, let's get it right, are metropolitan centric.
Yes, I guess so. Yes.
Okay, and this cannot be generalized. Well, the things like insurance penetration going up, fair enough, it is. If you ask me what should be done for larger good is that Government of India and even the state governments should hike their expenditure on health, and all they can stop all these Prime Minister Yojana, Rajiv Yojana, this Yojana, that Yojana, put them all together, and then increase. When we started our career, the public health was still very robust, and today public health is in a very pathetic state. For God's sake, these people should get together, increase the spending, and instead of depending on the charity of the charitable, I think the government should say, this is my responsibility and let me do it. And with I always keep saying that in PPP, it's the private which gets benefited than the public. So, I mean, these are all long-term views which should be considered, looked at, and implemented to my point, as far as I'm concerned. And I do sometimes, of course, and I have a very simple rule in my department: if you're rich, you pay; if you're poor, we'll try and help you to pay. That's very simple, and there are a lot of NGOs and etc. to help us, and also optimize the cost. So and don't give everybody a volumetric IMRT or SRS, and this that etc. and fatten your balance sheet. I mean, if a combination of all this can make it more affordable, equitable, so on and so forth, but government, both state and center, should step in and take appropriate steps. And I think there's a white paper which I've not read. I've downloaded something about the impact of all these yojanas, and there's a lot that needs to be done in spite of all these yojanas.
That's very well said, sir. Optimizing the technology. There is an effort from the Government of India. They brought in called the National Cancer Grid. They're trying to at least give some common minimum, advice, like what we could take for most of the patients. But when it comes to that implementation, what do you think is the role of clinical trials and audits in closing the care gap? From your side, sir. Doctor, I'll start with Dr. Hulgal. You're this one. How am I doing an audit of utilization of my technology, what I'm having?
So my
how do you
think? Clinical trials has been doing my own, very few of them, and being referee in couple on occasions. So what I do see is very often it's a Me Too clinical trials that we do it in India, and more clinical trials which are relevant to us, our problem, should be tried, and then yes, they are very, very important. But let's address our question the way we should address, and not just the Me Too trials.
Very well said. I always felt like, for example, CS cervix. I think we are the ones which have the higher, burdens of the 3Bs and above. And when you compare the literature, what we have produced, there are very few except the brachytherapy trials and ones who come out from Tata. We have not been the pioneers to say that this is how it has to be stage-wise in cervix. So there, I would like Dr. Kulkarni you also to come in. I saw that you had introduced certain technology which would be better utilized here, like cystectomies that you had introduced. Would you like to, how do you feel that a change according to our thing is going to help here?
So like this, what is happening was, when we started doing cystectomies for bladder tumors, and I realized that the problem of the post-op stay in ICU was much higher. So I devised a new technique which is called extraperitoneal, which I don't want to go into the technical details, of course, which got me award and everything back in 2000. This was to reduce here hospital stay, and what we call now is, which is being now taken into ERAS protocol. So you create, as the peritoneum was between the bladder and the bowel. So I tried to mimic that, and it helped me. And this also, and in females, what we tried was in cystectomies, we were doing hysterectomy early. So I started with, gynac tract pairing cystectomies. Again, these are very special cases which we can help it, but these are all the innovations which we developed over the years, having had a lot of surgeries being done at Tata Memorial, which used to be the gold mine for us. Again, that is a technical or theoretical problem. My current today problem in bladder cancer is how can I save the bladder? I'm not in a position to replicate the bladder by whatever means, this bowel, that bowel. My aim is today to consider anything which will, even muscle invasive bladder cancer can be saved the bladder and bring him back to what he belongs, and then get him some kind of quality of life. Metastatic disease is a different ballgame, but at least in a localized disease. So that's what we are working on to that. That's what this is what I can say today.
Dr. Chandi, sir, so what do you think is the impact of clinical trials, more so with the advent of treatments like immunotherapy, which have come in there? How well are they utilized, or the other way? How overutilized are they in practice, do you think so?
In my mind, any tertiary cancer care center must have regular audits of what it is doing and compare their outcomes. So if we're doing ripples in Tata Medical Center, my surgeon must be able to tell me that in the last 100 ripples, this is our perioperative morbidity, this is our mortality, this is our outcome, this is our follow-up, and this is an ongoing, absolutely essential process by which a center compares its functioning with international benchmarks. So that's one thing. Second is clinical trials. I believe they are very useful. One, because you study these new molecules in your own population and may come up with differences. Two, it gives patients access to molecules which they would otherwise never have access to. Three, it teaches clinicians how to do a trial, how to analyze data, how to coordinate the statistician, how to ultimately publish. So clinical trials are definitely useful in tertiary cancer centers, and I think they should be encouraged. And I'm very glad that the pharma is coming forward. We have a compassionate access program for some of the latest molecules, and you cannot believe it. In the last 1 year, 70 crores worth of compassionate access drugs provided free of cost to the patient. So that is where we can go. But there is no substitute for investigator-initiated trials where the doctors are involved. And that way, I'm very happy that at our center, most of our juniors are very happy to do audits. They use RedCap, they use the best statistical software, and they all are willing to attend GCP training courses in research methodology. And this is very encouraging for me.
Thank you, sir. Dr. Hulgal said this, I thought we'll close this with last question, which I would address to all three of you. What this ongoing pandemic, COVID-19, how has this impacted your practice on the QLs in relation to radiation oncology from what patients you're seeing?
Yes, well, I think there is, especially the first one, there's a lot of fear and the number of patients really dipped. And we did, in some cases, did fall back upon hyperfractionated radiotherapy. And also, of course, making RT-PCR mandatory for every patient who came in, and restricting the patients and taking care of the technical staff and our own staff who would be coming face-to-face with patients, all of these precautions. I'm very happy that we did not really stop treatment even for a day. And except that the number of patients coming from outside Mumbai really drastically fell down or almost nil. And I think it was okay, except and in terms of, I think 3 or 4 of us got COVID, I guess, but then that could, maybe we got it somewhere else. That's okay. I think no mortality from the staff, no excess mortality in the patients. We did not stop in some places. We did use our hyperfractionation, but not extreme hyperfractionation like some people did.
Dr. Kulkarni, what about you? How was it?
Well, of course, for first, when this, around February 2020, when the thing started, first 3-4 months we stopped robotic surgery completely because we were not sure what we are heading for. By come June 2020, we started slowly doing that. Again, the second wave came. So there have been waxing and waning kind of things happening. Now, also, luckily in my specialty, there is something which is called neoadjuvant hormone therapy or is available. So we could defer the surgical treatment for various reasons because patient not coming to. So that has happened. Of course, there has been no death because of COVID in the sense that he could not be treated or she could not be treated for the cancer. That was possible. Obviously, it is at a low level, but we could do that. Now, of course, after this, again, third wave, so-called Omicron or something, we have realized that the patients are now getting slowly to the hospitals, and we are in a position to do that. Of course, not as it was 2019. We have vaccinated ourselves, and we have encouraging. One of the questions which was asked by all the patients and relatives were, can we give him vaccination? I said, yes, you can give him, because cancer doesn't say that you could.
Yes.
That's the message which I used to tell them. Please go ahead with vaccination. No problem at all. And the others, our staff members who were going injections, say for instance, Lupride injection, something, we could manage to do it in the local GPs, and that was possible. Societies were not allowing people, but we could, with a proper note or something, understanding that could be done. So that's possible, yes. Nobody has died because of not getting treatment for cancer. Luckily, that's the message which I would like to give to all people.
How has it been, sir, Dr. Chandi, in your practice?
I think COVID has taught us a lot.
Yeah.
Taught us that we don't have to travel and destroy our environment. We can communicate effectively on the internet, and that has been really good that we could do that. 2, it has taught us a lot because that initial fear and paranoia has gone away.
Yeah.
And I'm happy to say that in our own center, we did not close even for a day. Cancer services continued. It came down because patients didn't come, but not because we were not there to offer the services that were available. But it has changed practice. For instance, if I'm doing a bone marrow transplant today, I don't want my donor to get COVID when I've already conditioned my patient. I cannot delay it.
Okay.
So therefore, we are actually harvesting and cryopreserving the blood so that we don't have a situation where a donor has become COVID positive and cannot give stem cells on the day that I'm supposed to do the transplant. So we have changed the way we practice, and obviously we do defer intensive chemotherapies for at least 2 weeks if the patient is COVID positive, because we do know that outcomes are bad if they are COVID infected and we give intensive chemotherapy. So a person with AML, if he's COVID positive, may go on to azacitidine and not on intensive chemotherapy till he gets over his COVID. And I'm happy that most of the healthcare workers have come around to treating COVID like any other viral infection, taking precautions, providing adequate personal protective gear, but not having the intense fear and worry that was there in the first and second waves.
Was there an increase in hospitalizations just because of this?
In our own staff, we've studied the 3 waves, and the rate at which the third wave progressed in our staff, 350 of a workforce of 1,200 got COVID. Thankfully, no hospitalization. All were home care, and nurses were put in a special place where if they couldn't go home, and they returned to work. The majority of our workforce were given 7 days of leave and they returned to work. Thankfully, the third wave did not disrupt hospital operations the way the second wave
did. Yes. Yes.
We had to provide transport to take our staff back. Public transport was not working. And therefore, third wave has actually gone so far relatively peacefully. And we made provision to have negative pressure isolation for all our cancer patients.
Okay.
Albeit 20 beds, but any cancer patient who needed admission with COVID got admitted and got cared for. But there were limitations to the number because we are a cancer hospital. We can't have COVID patients all over the place. They had to have a separate negative pressure facility, which we created.
That's nice. So I think that would be the last question from my side. It's been a pleasure to interact with all the three of you doyens here. And I think the message that I got from all of us in a nutshell is optimization of technology and training of personnel, where the private sector steps in a more interactive manner with the government sector in training our own personnel. And more importantly, like Dr. Chandi has said, dialogue with the legislature to increase the number of personnel at every level, including radiation as well as in medical oncology. Probably that is the key. The rest would definitely follow now when we start, concentrating on treatment. Then the screening programs follow by themselves also. So, thanking all of you, sir. It's been a pleasure to interact with all of you.
Thank you.
And to have a nice day.
Thank you so much to the esteemed panel for such a riveting session. If you have any questions or queries, feel free to reach out to us or drop your questions in the Q&A box on your screen. So do not miss out on the sessions planned for the next 2 days. Please take care and have a great evening ahead. Thank you so much.